This is a brief video on somatic symptom disorders and factitious disorders as they're listed in the DSM-5. We're going to be talking about somatic symptom disorder, illness anxiety disorder, conversion disorder, factitious disorder, and malingering as listed on the left side. Let's get started with somatic symptom disorder. Somatic symptom disorder is also called somatoform disorder. It was also previously called somatoform disorder or somatization disorder in the older versions of the DSM. Now it's referred to as somatic symptom disorder. It is defined as when a patient has at least one somatic symptom, such as pain, along with fear, worry, stress, or behavioral change regarding this pain. So a patient has a symptom, such as pain, and they have severe anxiety, worry, and stress surrounding that pain. The duration of their symptom and their fear, worry, and stress surrounding that symptom lasts for a duration of 6 months. That's a requirement for the diagnosis. Somatic symptom disorder is similar to illness anxiety disorder in that there is fear and stress surrounding the symptom, but in this patient, there is actually a symptom. In illness anxiety disorder, as we'll talk about in a second, patients have the fear, stress, worry about getting ill, but they don't actually have pain. They don't actually have a headache or a stomach ache or say a leg pain or a difficulty walking. There's actually a pain here. In somatic symptom disorder, the symptoms is or are subconsciously driven. Patients actually believe they have a disorder and they actually feel that disorder. So it's important not to disregard a patient's symptoms just because nothing fits, just because it doesn't match what you see on physical exam. A patient might actually be experiencing that stomach pain. A patient might actually have that severe heartburn and be very worried about it. A bit of epidemiology. This is more prevalent in females. The prevalence amongst the population is estimated to be around 5 to 7%, and there are a couple factors that make people more likely to present with somatic symptom disorder. This includes low socioeconomic status, low education, older age, and unemployment. Prognosis for patients with somatic symptom disorder is that the symptom can get better or worse. It's hard to predict, but oftentimes it follows a pattern based on mood and stress. If they're going through a high stress period, their headache that is unexplainable might get worse. If they're in a better mood one day, they might complain less about the heartburn that they've been getting. Patients often present frustrated, having seen many doctors that do not believe their symptoms, and they often have many negative workups. So a lot of times they're thought of as going doctor shopping, going around doctor to doctor until they can find one that believes them or one that is willing to stick with them through somatic symptom disorder. In general, we're going to go over the management for somatic symptom disorder. You need to acknowledge their symptoms because they could actually be real. The patient could actually be in pain. You should schedule regular follow-ups with a single primary care provider. There's a couple reasons for this. You want to build rapport with your patient. You want that patient to have regular visits with primary care provider so that they see a regular face, somebody that can follow their symptoms. And this should also help you monitor any changes in symptoms that patient may experience over time. If somebody comes in with the same complaint every time and it's a minor complaint and there's no cause that you can identify, at least you'll know that they did that last time if you're sending them to the same provider. Also helps you avoid unnecessary workup and treatment. If a patient comes in with unexplained back pain, for instance, maybe you did a workup a long time ago and didn't show anything, and then they still have that same baseline back pain, and it can prevent you from doing any more workup or treatment that would be unnecessary. Next is illness anxiety disorder. This is previously called hypochondria, hypochondriasis, also called health anxiety. This is defined as an excessive and undue fear, worry, stress, or behavioral change regarding having or being diagnosed with a serious illness. So it's essentially like anxiety about having a disease, illness anxiety disorder. Again, this one has to last for 6 months in time to make a diagnosis. Somatic symptoms can be present here, but if they are, they should be very minor. It should be something that isn't a big deal at all, isn't something that the patient is very concerned about. In somatic symptom disorder, they might have abdominal pain that hurts them really bad and they think they have gastric cancer, or heartburn and they think they have gastric cancer. But here in illness anxiety disorder, it's usually very, very mild, maybe like a stomach cramping that isn't feeling really well, or maybe they have constipation because they don't go to the bathroom for 2 days in a row, and then it relieves every once in a while, and they panic about it and think they have a colon cancer. Very minor symptoms. Main definition of illness anxiety is their preoccupation with their illness. And in this disorder, as with many of the other psychiatric disorders, it needs to impact their daily functioning. This could mean missing doctors or missing work time to go to doctor's appointments, or forgetting to pick up your kids from work because you're so worried and you had to go to the ED and get this checked out. It impairs your daily tasks. Sometimes illness anxiety disorder can be caused by a recent psychological stressor. If somebody recently got a divorce, maybe all of a sudden they are worried about their own health or worried about the health of somebody else. If somebody's aunt recently died of cancer, they might be worried about that cancer in themselves all of a sudden. So an example is if there's a sudden death in family, they might worry about that same disease in themselves. Reassurance in these patients is often ineffective, unfortunately. They're fixated on the thought that they could have a disease or could develop a disease. Epidemiology here, male to female ratio is about the same. 2/3 of patients that present with illness anxiety disorder have another psychiatric illness, and this is most prevalent in young adult ages, 20 to 30 years old. Management for illness anxiety. You want to acknowledge the concerns of your patient. You want to schedule regular follow-ups with a single PCP again. Psychotherapy, or cognitive behavioral therapy specifically, has been shown to help. And you can screen for comorbid anxiety and depression because 2/3 of them will have a comorbid psychiatric condition. And if that is the case, you can consider an SSRI to reduce that stress and hopefully therefore reduce the illness anxiety disorder. If there is a recent stressor in their family, you can counsel them about that. You can provide supportive therapy regarding that as well. So resolve the stressor if there is a psychological stressor. Next is conversion disorder. Conversion disorder is also known as functional neurological symptom disorder. Patient presents with at least one symptom, and this is usually a neurologic symptom, such as numbness, blindness, mutism, or paralysis. This symptom cannot be explained neurologically. For instance, it's not in the normal stroke pattern, or it doesn't make sense. Usually when somebody has numbness, it's in a dermatomal arrangement, but in conversion disorder, it doesn't necessarily need to be in a dermatomal arrangement. If a patient comes in complaining of paralysis in an arm, when you're not looking and when they're not thinking about it, they might be able to move that arm unintentionally or maybe intentionally to scratch their head when they're not really thinking about it. So it doesn't really make sense neurologically. And similarly, it doesn't match with the neurologic workup that you do when they come in. So symptom onset is usually abrupt and often follows a significant life stress or event, such as death of a family member and bereavement, such as a person who's reading on Facebook that their partner broke up with them, and then all of a sudden they become blind, or a person whose mom just died and is dealing with the grief of that, and all of a sudden can't walk and their legs become paralyzed. Patients are often indifferent or unconcerned with their symptoms. They don't care. And there's a French term that describes this called la belle indifférence, and that essentially means that they're indifferent to their symptoms. Their concern for their symptoms is very low proportional to the severity of their symptoms. If somebody's legs are paralyzed, you would think that they'd be pretty concerned that their legs are all of a sudden paralyzed. But maybe because of the recent life stress or event, they are less concerned. They are indifferent to their symptoms. This is more prevalent in women than men, and it most frequently occurs in adolescence and early adulthood. Another symptom that can present in conversion disorder is a pseudo-seizure, also called a psychogenic non-epileptic seizure. And this essentially can be differentiated from a normal epileptic seizure based on prolactin levels, which are elevated in epileptic seizures but normal in pseudo-seizures, and EEG readings, which are normal in pseudo-seizures but show epileptic activity in epileptic seizures. So pseudo-seizures, or what would look like a grand mal tonic-clonic seizure, can be the presenting symptom of conversion disorder. Management for conversion disorder, main thing you want to do is educate the patient about the disease. You want to reassure them that their symptoms will resolve and that they are not permanently affected. You can consider CBT if their symptoms persist after some time, but usually it does resolve. Factitious disorder is next. This is also known as Munchausen's syndrome when it is very severe. So severe cases of factitious disorder are called Munchausen syndrome. Now, factitious disorder is essentially when a patient acts as if they have an illness by deliberately producing, feigning, or exaggerating symptoms. What's important here is the patient's goal in doing this, the patient's goal in deliberately feigning symptoms. The patient wants to attain the patient's role with no secondary gain or external reward. They purely want to be a patient. They want to be sick just to be treated as if they are sick. They want to be a patient. No secondary gain. They're not trying to get money. They're not trying to get insurance benefits. They're not trying to get out of work. They're not trying to get drugs. They just want to be a sick patient. Patient often creates symptoms in dangerous ways. Two classic ways that come up on the boards a lot are injecting themselves with feces to induce infection, injecting themselves with excess insulin to induce hypoglycemia. Sometimes they would ingest blood and then make themselves vomit to make it look like they vomited their own blood and have a bunch of gastric workups done there. But those are some examples of how patients can, in dangerous ways, create symptoms. And of course, they can make it less serious, such as complaining about abdominal pain, depression, and hallucinations that aren't really there. The patient can present themselves as the patient, or sometimes the psychiatric condition has them present another person as a patient, and that would be called Munchausen's by proxy. An example of that is a distressed mother with comorbid depressive disorder presenting her daughter as being injured, or infecting her daughter with something and presenting her daughter as a patient. That would be called factitious disorder by proxy, or Munchausen's by proxy. And of course, if a patient is making their child sick intentionally, purely to attain a patient's role for their child, that is, of course, child abuse. This often occurs more frequently in women than men, and there's a higher incidence in healthcare workers. So a lot of times on board questions, you would see an ex-nurse or a current nurse that's presenting with factitious disorder, or maybe a doctor, somebody who knows the healthcare system is better able to manipulate the healthcare system and present with factitious disorder. Management here is to confront the patient in a non-threatening manner. You want to document everything very well and contact their primary care provider and other providers to avoid unnecessary procedures. If somebody is known to be presenting with factitious disorders, you want to make sure that they are not going to another hospital or to another doctor to get the same workup and waste more resources that way. Lastly is malingering. Malingering is when a patient fabricates symptoms of mental or physical disorders for a secondary gain or an external reward. So in malingering, the patient is not interested in playing the patient. They are not interested in being in the sick role. They're interested in benefits that comes with being in the sick role, such as insurance benefits, getting out of work, getting drugs. Secondary gain is oftentimes getting out of work, school, obtaining drugs, clearing legal charges like pleading insanity, clearing their legal record with that, or getting free room and board, things like that. There's a secondary gain, an external reward to being sick. Malingering is not considered a mental illness or psychiatric pathology, and that's pretty important. It's actually not listed in the DSM-5, so it's not a mental illness. Oftentimes in malingering, the patient presents with an ill-defined or non-specific complaint that doesn't add up. For instance, something just vague like fatigue. They might present themselves to the ED with just excessive fatigue or excessive abdominal pain, or just like a general headache. And they usually get a workup and are often unsatisfied with that workup, or unsatisfied with the reassurance that they have nothing wrong with them. Of course, they do become satisfied and they do become reassured as soon as their secondary gain is achieved. And their symptoms also sometimes improve once the secondary gain is achieved. If somebody needs to get out of work and they present to the hospital to get out of work, once that work day is over, they might say, "Oh, I'm better, I'm free to go," and sometimes leave against medical advice once that secondary gain is achieved. This is more prevalent in men than women, way more prevalent in men, and patients that present with malingering sometimes have antisocial personality disorder, or a person with antisocial personality disorder is more likely to malinger than people without antisocial personality disorder. Management here is a little delicate. You want to present the patient with the discrepancies between the objective findings, the labs, the imaging, the physical exam findings, and the differences between those and their subjective report. Kind of point out that things aren't adding up. Give them a chance to come out clean. Give them a chance to admit that they've been malingering. You do not want to confront the patient with hostility. Oftentimes they'll leave against medical advice in that case. This has been a brief video on somatic symptom disorders and factitious disorders, including somatic symptom disorder, illness anxiety disorder, conversion disorder, factitious disorder, and malingering. I hope this was helpful, and thank you for listening.